fall of 2023, I was working a shift at a community hospital in the GTA when we got a patch. A 3-year-old girl was being brought in by EMS with an out-of-hospital cardiac arrest. CPR was ongoing. Her ETA is 10 minutes. We prepared the emergency department for the patient's arrival. The brief handover we got from EMS was that the patient had been sick with upper respiratory symptoms for 2 to 3 days, including a cough, fever, and rhinorrhea. She hadn't eaten much that day and had been vomiting. Then, 30 minutes prior, she suddenly collapsed in front of her mother. We checked her blood glucose and it was 2.5. We put in bilateral IOs and began administering glucose in addition to saline boluses. We did a bedside ultrasound, which showed that she had a large right pleural effusion, and we placed a chest tube during CPR, which produced purulent appearing fluid. We gave antibiotics through IOs and ran the resuscitation for 45 minutes, but unfortunately, we were never able to achieve ROSC. The next day, when I arrived for another shift, I was informed by my staff that the patient's blood and fluid cultures had grown group A strep. This patient had died of septic shock from an invasive group A strep infection. We spoke with ID, and I would need to take a 10-day course of prophylaxis with Keflex. Now, unfortunately, the tragic story of this 3-year-old girl was not so unusual in the last year. In recent months, headline after headline has alerted us to the alarming spike of invasive group A strep. As of January 9th, the Public Health Agency of Canada, FAC, has received more than 4,600 invasive group A strep samples from 2023. This is the highest annual total ever recorded in Canada. In Ontario, 11 children died from invasive group A strep infections between October and March of this year. In BC, 4 children died in December alone of invasive group A strep infections. So what's going on? Why do invasive group A strep infections seem to be surging? And more importantly, what do we as emergency physicians need to know about identifying and managing these deadly infections? My name is Max Zworth. I'm one of the PGY4 emergency medicine residents here in Ottawa, and it's my privilege to speak to you today about invasive group A strep infections. Here's what we're going to do today. By the end of this talk, everyone here will be able to define invasive group A strep and streptococcal toxic shock syndrome. You'll have a better understanding of the epidemiology of IGAS in North America. You'll recognize when to suspect these infections in the emergency department. Next, we're going to explore the relationship between GAS pharyngitis and invasive group A strep and determine if any new approach to pharyngitis is warranted. Finally, we're going to discuss the protocol for chemoprophylaxis for people exposed to invasive group A strep. So I'm going to put some people on the spot here. Do you think somebody R1 to 3 could offer a definition for invasive group A strep? R4 or 5? Could any staff offer a definition of invasive group A strep? Mike? Yeah, exactly. So Mike says group A strep that's growing in a place it shouldn't be. So as we know, Streptococcus pyogenes is a species of gram-positive aerobic bacteria. These bacteria are the main species that have the group A antigen, and that's why we call them group A Streptococcus. There are actually a couple other bacteria that have the group A antigen, but group A strep specifically, when we grow them on blood agar, typically produce these small zones of beta hemolysis. And so that's why we also call them group A beta hemolytic streptococcus. For simplicity, we can just say group A strep. Group A strep typically causes a number of different infections, but most commonly this is pharyngitis or skin and soft tissue infections. So what makes these invasive? Like Dr. Ho said, invasive group A strep infection refers to infection in the setting of culture isolation of group A strep from a normally sterile site. So group A strep in a place it's not supposed to be. So a normally sterile site would include things like blood. Less commonly, this is pleural, pericardial, joint, or even cerebrospinal fluid. And keep in mind, with this definition, it means we can't actually make a diagnosis of invasive group A strep in the emergency department. We can only suspect it because we won't have culture results for at least a day or so. Generally, invasive group A strep is going to take one of these forms. It could be necrotizing skin and soft tissue infection or necrotizing fasciitis, pregnancy-associated infection, bacteremia, or respiratory tract infection. And we further divide invasive group A strep infections into those complicated by toxic shock syndrome and those that are not complicated by toxic shock syndrome. Streptococcal toxic shock syndrome is a complication of invasive group A strep disease, which is characterized by shock and multi-organ failure. And it develops because of capillary leak and tissue damage from the release of inflammatory cytokines, which are induced by the streptococcal toxins. Toxic shock syndrome has a very specific case definition according to the CDC. So in order to meet criteria for toxic shock syndrome, you need to have both isolation of group A strep from a sterile site in order to be confirmed, and then you need to have clinical signs of severity. So this includes you must have hypotension and then 2 or more of fever, rash, renal impairment, coagulopathy, liver function abnormalities, ARDS, or tissue necrosis. We think that somewhere around 1/3 of patients with invasive group A strep will progress to meeting criteria for toxic shock syndrome, though the number that become really sick and don't quite meet criteria is probably much higher. And this number is as high as 50% when it comes to necrotizing fasciitis. So with definitions out of the way, let's talk about the epidemiology of invasive group A strep infections and what's going on in North America recently. So invasive group A strep infections are deadly. In fact, it's one of the leading causes of death attributable to a single pathogen worldwide. So amongst causes of death caused by a single pathogen, it's the 9th leading cause of human mortality around the world. Estimates vary based on studies, but fatality rates from invasive group A strep infections are estimated to range from 11% to as high as 60%. These infections are also elusive. In up to 45% of cases, no portal of entry for bacteria is found. The most common presentation is skin and soft tissue infections. But as you can see here, the second most common presentation is occult bacteremia. And this makes these infections very difficult to catch. We think that in many cases of isolated bacteremia, skin is actually still the portal of entry, but it's hard to capture this in data. These infections are also not isolated to children, despite these being the cases we hear most about in the news. There seems to be a bimodal distribution of invasive group A strep infections. So infections peak before the age of 2, but then prevalence begins to increase after the age of 50. And these infections tend to occur throughout the winter and early spring in North America. So they have a temporal distribution, kind of like we're familiar with in our viral season. But finally, these infections are in fact increasing in frequency. So invasive group A strep infections more than doubled from 2009 to 2019, from 4 cases per 100,000 to 8.1 cases per 100,000. And then we saw a slight decline during the pandemic, but cases reached a new peak in 2023. As you can see, it's pretty dramatic. There's a much higher caseload than we've ever seen in Canada before. In Ontario, we saw a 62% increase in cases over the last year with a 13% fatality rate. And again, these cases are not isolated to children. And so as you can see, while cases have been increasing across the board, the sharpest rise in these infections occurs in adults in recent years. Now, while these cases are on the rise, it's still worth putting things in perspective and pointing out that these infections are extremely rare. For comparison, cellulitis is the 9th most common reason people seek medical attention in emergency departments in North America. 4 out of every 10 adults in the US seeks medical care for a soft tissue infection each year. And the incidence of lower extremity cellulitis alone, so not including all other forms of cellulitis, is somewhere around 200. I don't know what's going on with our slides here. It's somewhere around 200 per 100,000 people. And again, the comparison was that the rate of group A strep right now is somewhere around 8 cases per 100,000 people. So while these infections are deadly and they're scary, they still make up a tiny proportion of the patients and the patients with skin infections that we're going to see in the emergency department. But so what does explain the sharp increase in invasive group A strep infections in recent years? So group A strep has several cell surface molecules and secreted products, and these are known as virulence factors. The most important of these, which is on the right there, is known as the M protein. The M protein is a cell surface protein that's encoded by the M gene, It protects the organism against phagocytosis. But because mutations of the M gene are constantly emerging, we can use these M types to categorize and type group A strep infections. So for example, from the 1980s through the 2000s, the most common strain of invasive group A strep by far was known as the M1 global strain. But in England, during the 2015 to 2016 season, there was a big spike in both invasive group A strep infections and then also cases of scarlet fever. And this seemed to be associated with the emergence of a new strain of GAS known as the M1 UK strain. Researchers have observed that the prevalence of this M1 strain has been increasing in prevalence around the world. And it's been theorized that this new M1 UK strain may be responsible for the surge in cases that we're seeing now in North America. So far, though, this hasn't really been shown in literature. There's no clear link between the M1 UK strain and the cases we're seeing here. So for example, this was a study of another outbreak in London, UK from December 2022. And they found that of this outbreak, only 12% of cases were this new M1 UK clone. There was another study in BC, also from December 22, and they found no general M type that they could point and say this is where most of the infections are coming from. At the same time, though, then there was this study from Belgium, which looked at 86 cases of group A strep in ICU between 2022 and 2023, and they found that 73% of cases were of this M1 UK strain. So this strain probably is contributing to the growing cases we're seeing, but it's likely only part of the picture. For example, some people have suggested that we actually lost some of our immunity to group A strep during the pandemic, and that's why cases seem to be rising. Others have suggested that because we're more susceptible to viruses now than we were pre-pandemic, when we do get viruses, that in turn makes us more susceptible to group A strep infections. And finally, it's likely that climate change and globalization may be playing a role in ways that we don't yet understand. So with all that said, when should we be suspecting these infections in the emergency department? So let's go through some cases and figure out when we need to consider these infections in the emergency department. So you're on a recess shift at the Civic, and your first patient in emergent care is a 62-year-old woman presenting with a red and painful leg. She has a history of type 2 diabetes and hypertension, and a few days ago she bumped her leg on a table. For the last 24 hours, she's had right leg pain and redness. On exam, she looks unwell. Her heart rate was 130, her blood pressure is 95/70, her respiratory rate is 22. She's febrile at 38.5. Her shin is erythematous and warm. There's some induration, but you think that she has pain out of proportion on exam. So how should we approach this patient? As a reminder, roughly 40% of cases of invasive group A strep infections present as skin and soft tissue infections. And so with that said, the first thing we have to be able to do in order to catch invasive group A strep infections is recognize necrotizing fasciitis. So NECFASH has been covered extensively in the past, both in grand rounds and in core rounds taught by Dr. Yadav. And so I'm not going to spend a lot of time on this. There are some important points that I do want to highlight, though. So Dr. Yadav and his team recently developed an emergency department best practices checklist for skin and soft tissue infections. You can find a link here to the entire guideline. It's been endorsed by CAPE and is going to be published in CGEM in the next few months. The guideline recommendations were developed by reviewing existing guidelines, systematic reviews, relevant literature, and then they also adapted the recommendations specifically for a Canadian emergency department context. And so one of the questions in this guideline is, when should emergency physicians suspect necrotizing fasciitis? And an important take home from the guideline is that we need to be using our clinical judgment to make this diagnosis. There are some features that clinically can suggest the involvement of deeper structures in a skin and soft tissue infection. So these include pain out of proportion, a hard wooden feel of subcutaneous tissue, signs of systemic toxicity, crepitus, bullous lesions, or skin necrosis. And there are some exam findings that have been shown to have pretty good specificity for making a diagnosis of NECFASH. So as you can see here, hemorrhagic boli in a patient with a skin and soft tissue infection has a specificity of 96%, hypotension, a specificity of 98%. But the sensitivity of all these exam findings is extremely poor. So you can't look at a patient and say, well, they don't have these findings, so I'm reassured that there's no diagnosis of NECFASH. The guideline also addressed the question of whether there's a role for imaging in making a diagnosis of necrotizing fasciitis. In 2019, Shannon Fernando and colleagues performed a systematic review looking at the diagnostic accuracy of imaging in diagnosing neck fash. And as you can see, the sensitivity of X-ray for making a diagnosis is extremely poor. So we cannot rely on this to rule out a diagnosis. And CT is better at 88.5%, but still not good enough. The specificity of these tests, though, is actually pretty good, which means that if you do see gas on a CT or X-ray, neck fash in this patient is highly probable. But another major concern with CT is that if we're getting a CT scan in these patients, it will delay surgical consultation, which is really what we require for definitive diagnosis and management. And so for that reason, the working group recommended that clinicians not be relying on imaging tests to help diagnose necrotizing fasciitis. Having said that, that doesn't mean that CT is not helpful in necrotizing fasciitis. So for example, let's say a patient has a severe soft tissue infection on their upper shoulder. A surgeon might need a CT in order to determine if that infection extends into the chest, because that has a huge determinant of which surgical service is going to take care of that patient. Because if it does extend into the chest, thoracic surgery will likely need to be involved. And so the message here is not that CT has no role in necrotizing fasciitis, but that we as emergency physicians should not be relying on CT or X-ray for making the diagnosis. What about laboratory investigations? Can we use blood work to help rule in or rule out a neck fash diagnosis? Many of us will be familiar with the ELRINEX score, and this is a score that uses a combination of lab values to assign patients with a risk level of neck fash. And scores greater than 8 are generally considered high risk. That same systematic review also looked at the accuracy of the ELRINEX score for diagnosing neck fash and found that overall it performs quite poorly. As you can see, the sensitivity for a score of greater than 6 is only 68%. Sensitivity for a score greater than 8 is only 40%. But again, the specificity is pretty good for extremely high scores of greater than 8. So if a patient has an ELRINEX score of greater than 8, there's again a high probability that they do have neck fash. But because of the poor sensitivity, if you suspect neck fash, you should not be reassured by normal lab values. And here you can see the group's recommendations, which is that decision tools should not be used to rule out the diagnosis of neck fash due to its poor sensitivity. I spoke to Dr. Jacob Hardy, who's a fifth-year plastic surgery resident here in Ottawa, to get a surgical opinion about making a diagnosis of necrotizing fasciitis, and he had a useful approach, so I'll take you through it. He said, I mentally categorize patients into 3 boxes. 1, highly suspicious of neck fash. 2, moderate or unsure, and 3, definitely not neck fash. Things that pull me towards 1 are instability, acute and rapid onset on history, spreading, even within the time that you are seeing the patient, presence of hemorrhagic bullae. Things that pull me towards 3, i.e. not a diagnosis of neck fash, is something that is for sure not neck fash. Rock solid vitals, slow and indolent course on history of cellulitis and rash, absolutely no pain out of proportion, and a non-progressive infection. Dr. Hardy said that unsurprisingly, the most difficult group to parse through for the ED doc and the surgeon is group 2. These patients have some features of neck fash, but others that don't point towards neck fash. Looking infection, but also tell you it's been grumbling for about 3 weeks. They have a white count of 30, but what appears to be mild cellulitis. On repeat exam, they have some areas that have spread and others areas that have regressed. If stable, these patients should be further worked up. We shouldn't group them into 3 and dismiss them, but we shouldn't group them into 1 and operate on them. If they are unstable, they are automatically group 1 and surgery should see them right away. Dr. Hardy suggested that these patients in group 2 are the patients in whom surgeons find things like CT and blood work helpful. He said as long as these patients are stable, as a surgeon, he wants to gather as much information as possible. So the most important points for diagnosing neck fash are as follows. First, necrotizing fasciitis is a clinical diagnosis. Imaging should not delay surgical consultation and treatment, and we should not be relying on labs to rule in or out the diagnosis. So we know how to diagnose neck fash, but again, somewhere around 25% and even as high as 40% of cases won't present with any skin or soft tissue infection. And so the question is, which patients without a skin and soft tissue infection should we be suspecting invasive group A strep in? Unfortunately, we don't have very much evidence regarding the syndrome of invasive group A strep without necrotizing skin and soft tissue infection. I spoke to Dr. Fahad Chowdhury, who's an infectious disease physician here at TOH. He explained that the pathophysiology of invasive group-based strep or toxic shock syndrome is the same as toxic shock syndrome from neck fash. And so for that reason, it's multi-organ failure secondary to streptococcal toxins. And so for that reason, the same things that we look for when we diagnose neck fash, we should also be looking for in order to suspect invasive group-based strep. So here are some clinical situations in which you could consider invasive group-based strep as a cause and treat empirically. One is syndromes that seem to be rapidly progressive. A second is patients who are hypotensive and unstable despite aggressive and good sepsis care. The third is the patient who's progressed rapidly, who's critically ill and septic appearing, but with no obvious source. And then there's two other groups of patients that we should be thinking about these infections in. One is patients who are peripartum or post-op. And then the last is varicella infection, because there is some association between invasive group-based strep infections and recent varicella infections, particularly in kids. Dr. Chowdhury also pointed out that in most cases of invasive group-based strep without any source, we still think skin is the portal of entry. And so in these patients, it's really important to perform a thorough head-to-toe exam, looking for even minor signs of trauma that could point you towards this being the cause. Finally, he also pointed out that the insecurely housed are disproportionately at risk of invasive group-based strep infections. So you have a patient who's homeless who presents in one of these ways, it should also prompt you to think about this. The other thing I would also point out is that you should be thinking about this in the patient with pneumonia who seems to be progressing rapidly. So again, this is only a case series, but that same Belgian case series from ICU that we looked at earlier found that among those admitted to ICU with group-based strep infections, 45% of adults had a pneumonia and 77% of children had a pneumonia. And a significant proportion of both of those groups progressed to an empyema. I spoke to Dr. Yadav, who is obviously our local expert on skin and soft tissue infections, but also a leading researcher in North America on the topic. And he had the following to say. He said, "We see a ton of sepsis, but invasive group-based strep, these patients deteriorate in front of you. Look for clear signs of evolution and consider it in fever without a source. Perform a good head-to-toe exam and consider the diagnosis in the patient not responding to usual sepsis care." So coming back to our case, what stands out here is that this patient's symptoms have progressed rapidly over 24 hours. She has unstable vital signs in the context of a skin infection, which includes hypotension. She's febrile and she has pain out of proportion. So for these reasons, we suspect necrotizing fasciitis. So in this patient in which we're suspecting, an invasive group-based strep infection, how are we going to change our management? There are four general pillars of managing invasive group-based strep infections, and they are our usual sepsis care, source control, specific antibiotic therapy, and then IVIG. I'm not going to go over the usual sepsis care, as we as emergency physicians are all quite comfortable and familiar with this, but I am going to briefly touch on the other three. So let's talk about antibiotics. There's nothing new or groundbreaking here. You all know that this is the antibiotic regimen for a patient with neck fash. Interestingly, group-based strep remains universally susceptible to penicillins. We don't know exactly why that is, but so even for patients with invasive disease, penicillins are the mainstay of therapy. In patients who are penicillin allergic, a carbapenem is recommended as an alternative beta-lactam agent. So meropenem at a dose of 1 gram or 20 milligrams per kilogram is an appropriate dose. Second, remember that in the emergency department, we actually don't have a diagnosis of invasive group-based strep. We can only suspect it. And so vancomycin is included not because it's essential for the streptococcal toxic shock syndrome, but it's part of our cocktail for the really shocky septic patient so that we can empirically cover against MRSA, particularly in necrotizing skin and soft tissue infection in which Staph aureus might also be implicated. Clindamycin is also a critical component of our management of invasive group-based strep infections. And there's a few reasons for this. So first, clindamycin is not affected by bacterial loads. So penicillins work really well against group-based strep, but it's limited by something called the inoculum effect. So when you have really high bacterial loads, penicillins don't seem to work quite as well. But that's not true for clindamycin. Clindamycin will work no matter how much bacteria a patient has. Secondly, clindamycin, as we know, inhibits bacterial toxin production. And so because toxin production is a major component of toxic shock syndrome, clindamycin helps combat that. Finally, though, there's also good evidence that clindamycin significantly reduces mortality. So in this retrospective study of 2,000 invasive group-based strep infections in the United States between 2000 and 2015, mortality was 6.5% in patients who received clindamycin compared to 11% in patients who received a beta-lactam alone, which leads to an odds ratio of 0.44. I should also point out that we've begun to see some resistance in group A strep to clindamycin. So in the United States, between 2000 and 2015, resistance went from 1% up to 15%. For some reason in China, 97% of isolates of group A strep are resistant to clindamycin. But for now, clindamycin remains a mainstay of therapy in North America. Next, as we know, source control is critical in the patient with invasive group A strep. And in the case of necrotizing soft tissue infections, this means urgent surgical consultation. I've included the recently updated TOH algorithm for necrotizing soft tissue infections as a refresher for you. And so here we divide our cases by site. So cases involving the torso are going to go to general surgery. Cases involving the upper extremity are plastics, lower extremity ortho. Anything involving the perineum is going to be Fournier's, and we're going to need to involve urology. And if the chest is involved, then thoracic surgery needs to be involved as well. Generally, it's expected that if we do suspect neck vash, the resident should be assessing this patient within 15 to 30 minutes. In some cases, you might have a consulting service ask you to get a CT scan to further assess for neck vash. And if this happens, I think we need to be collegial. I wouldn't be a wall and say, no, imaging isn't indicated for neck vash, because as we said, there may be some valid reasons that you need imaging in this patient. So I'd probably say something like, absolutely, I can order a CT and I can call radiology to protocol the scan, but I also need you to assess this patient and offer your opinion. I also asked Dr. Hardy about, for his perspective on getting our surgeons involved when we suspect neck vash. And he said this: neck vash is a surgical disease. It requires prompt identification and prompt surgical debridement to avoid amputation and death. Whenever we see cellulitis in an unstable patient, neck vash must be assumed. In order to not miss neck vash, I think I must be willing to examine some patients who don't end up having neck vash, and sometimes even taking patients to the OR who don't end up having neck vash. A trigger-happy approach is reasonable in these cases, as while OR is not benign, the implications of missing neck vash are so severe that they easily outweigh these. And I want to underline this point. It's okay to have overcalls or false positives on necrotizing fasciitis. And by that, I mean, there should be instances in which we get surgeons involved and the patient doesn't end up having necrotizing fasciitis. Because if your hit rate on neck vash is 100%, it's likely you're missing some cases. Finally, let's talk about IVIG and invasive group A strep infections. So in 2018, Parks and colleagues conducted a systematic review and meta-analysis comparing IVIG to no IVIG in patients being treated with clindamycin for streptococcal toxic shock syndrome, with their primary outcome being 30-day mortality. They found that in every study, mortality seemed to be lower in the IVIG group than in patients who didn't receive IVIG. But because the case numbers were so low, none of these studies was statistically significant on their own. They then conducted a pooled analysis, though, and they found that IVIG seemed to reduce mortality from 33.7% to 15.7%. Because data are still limited, the IDSA currently says that further research is needed before a recommendation can be made. But Dr. Chowdhury did suggest that in patients with signs of severe infection where we're suspecting invasive group A strep, we should be considering IVIG early. The dose of IVIG is generally 1 gram per kilogram on day 1. As a reminder, we do have an order set at TOH for giving IVIG. You just type in IVIG, and it will link you to a Ministry of Health form that you're required to complete and send to transfusion medicine before you can give IVIG. And this ministry form also has a dose calculator that helps you calculate the exact dose for the patient. So to resolve this case, we diagnosed a necrotizing soft tissue infection based on clinical exam. Since we suspected neck vash, we empirically gave appropriate antibiotics. We also administered IVIG at 1 gram per kilogram, given the patient had signs of severe shock. Orthopedics was consulted, and the patient was brought to OR for definitive treatment. We did not obtain any imaging prior to paging ortho. So you cascade from emergent care over to RAS, and your next patient is a 24-year-old presenting with sore throat. He presents with 3 days of subjective fever, odonophagia, and dry cough. On exam, he's a little bit tachycardic at 115, but otherwise clinically stable, and he looks quite well. He's got a mildly hoarse voice. He's got tender cervical lymphadenopathy. And you look at his throat, and this is what you see. So show of hands, who's giving this patient antibiotics? And can anyone comment, what about this case makes you want to give this patient antibiotics? For those online, a lot of hands were raised. Right, so you see this patient's throat and you think to yourself, well, this could be the same bacteria that just caused that deadly infection in my patient over in recess. So do I need to be doing anything differently here? So we don't have great evidence about the association with group-based strep pharyngitis and invasive group-based strep infections. So this section of the talk is going to have a lot of caveats. Probably the best summary of evidence we have regarding risk factors for invasive group-based strep in children comes from this scope and review that was published in 2023. They asked the question, what are the predictors of clinical invasive group-based strep infection in children? And what are the most common localizations of different types of invasive group-based strep? So they performed a scoping review according to PRISMA guidelines. They included 200 studies in total, and they found 5 studies that had performed multivariate analyses of invasive group-based strep cases. They did not find any studies that had reported any cases of positive group-based strep infection prior to the onset of invasive group-based strep. So again, there were no cases in this review of a patient that had been diagnosed with a group-based strep infection and then progressed to invasive group-based strep. And I think that speaks to, one, how rapidly these patients present, and 2, the fact that maybe some of those patients who were actually diagnosed with group-based strep were getting treated. So this study concluded that in 2023, we're still unaware if a diagnosis of invasive group-based strep is preceded by a non-invasive infection or colonization with group-based strep. It is completely unknown if low thresholds for testing and treating group-based strep may have any effect on reducing invasive group-based strep incidence. But there are some limitations in this study that I want to point out. So only 5 studies included multivariate analyses of predictors of invasive group-based strep. And these 5 studies ranged from the year 2000 to 2015. So none really capture that new M1 UK strain that we're seeing after 2015. The study is also only in pediatric patients. And as we've said, the group with the highest incidence of invasive group-based strep are those over the age of 60. Finally, the study didn't capture any information about group-based strep in close contacts, only in the source patient. So should we be approaching pharyngitis any differently? So as a reminder, the vast majority of pharyngitis are still going to be viral. 80% of cases of pharyngitis are viral, with another 20% being bacterial. Another important thing to consider is that we already are prescribing way too many antibiotics. Antibiotics for sore throat make up 5% of all antibiotic prescriptions in Canada. So in Canada, we're giving on average 7 antibiotic prescriptions written for every 100 adults per year for sore throat. And only 50% of these are for confirmed group-based strep. So that means another 50% either were negative or weren't tested. And also, distinguishing group-based strep from viral pharyngitis is not easy. There are some features that point towards a more viral illness. So things like cough, coryza, conjunctivitis all suggest viral, but these things are pretty vague. Like the group-based strep, things that point towards a group-based strep infection here are headache. How many people have you seen with a viral infection who have a headache? The best tool we have to assist us in making diagnosis is the McIsaac criteria, or these are the modified Centaur score. Most of us will remember learning these in mid school. Large-scale validation of the modified Centaur criteria was done as recently as 2012 in 200,000 patients in the United States. And the score is still recommended in guidelines, including the CPS guideline and the UK's National Institute for Healthcare Excellence guideline. But again, we need to qualify this and point out the McIsaac criteria was validated on older variants of group-based strep. So we don't have any more recent data of how the Centaur score performs since with these new strains that we're seeing after 2015. And as you can see, so for those older strains of group-based strep, the Centaur score still doesn't perform that well. So even a Centaur score of 4, so this is a patient who has a fever, does not have a cough, has tender anterior cervical lymphadenopathy, and has swollen tonsils with exudate, that patient is still only going to be positive for group-based strep about 57% of the time. And then even if we are able to make the diagnosis, the question remains, do we actually need to treat group-based strep pharyngitis? So first of all, we know that up to 15% of children who test positive for group-based strep are asymptomatic carriers. So in that case, we're only going to be treating a viral pharyngitis basically with antibiotics, and what we're risking is the side effects of antibiotics. We also know from recent Cochrane review that 80% of patients with sore throat will generally be asymptomatic by 1 week, even if we don't treat them. So what we really think we're treating with treating group A strep pharyngitis is its complications. And we break those down into suppurative complications and non-suppurative complications. So there is a small reduction in the risk of suppurative complications. Those are things like acute otitis media or a peritonsillar abscess. But the rates of those complications are quite low. And so the number needed to treat is 200. So you would need to treat 200 people with antibiotics for 1 instance of a suppurative complication. And then when it comes to the non-suppurative complications, so things like rheumatic fever, glomerulonephritis, the rates in our population now are so low that we can't even quantify if there's any benefit in recent studies. Again, though, I would give the caveat that that data we have on the natural history of group A strep infections, that all comes from those older variants of group A strep. So we don't have data on how these new variants progress. And so we're basically making decisions to manage this surge we're seeing based on pre-surge data, which does have its limitations. So I asked Dr. Chowdhury about the potential association with group A strep pharyngitis and invasive group A strep, and he had this to say. He said, I don't think GAS pharyngitis is a major player in invasive group A strep infections. Anecdotally, it seems like one could lead to the other, but statistics-wise, we're just not seeing this yet. The spike we've seen in scarlet fever does suggest an increase in virulence, and there are some anecdotes about increased rates of rheumatic fever. But again, we're not seeing this yet in the data. He said, I would not do anything differently for pharyngitis workup and management. Dr. Yadav took a similar approach. He said, we have to be careful. There's no clear association, let alone established causation, between group A strep pharyngitis and invasive group A strep. But let's pretend there were. What would this change clinically? Does this mean anyone with a sore throat should get antibiotics? If we dramatically increase our antibiotic prescribing, we're going to get resistance. I don't think we should be changing our practice. So in that case, how should we be approaching pharyngitis? We generally have two approaches to choose from. The first is the IDSA guideline from 2012. They actually don't recommend using any scoring system. They suggest that if clinical features alone are not enough to distinguish, which as we said, they usually aren't, then you can use a throat swab or a rapid antigen test. As you can see, the performance of these tests for group A strep are actually quite good. So the rapid test has a specificity of 95% and a sensitivity between 70 and 90%. And then a throat culture has a sensitivity of 90 to 95%. The other caution, though, with IDSA is that locally our resistance rates to azithromycin are so high that we should only be prescribing azithro to people with severe penicillin allergies. So I would not be using azithromycin as a first-line treatment in group A strep pharyngitis. The alternative approach, and this is the guideline that probably mirrors our practice pattern more, is the National Institute of Healthcare Excellence guideline, so NICE guideline from the UK. This was published in 2018. And this approach recommends using either the Centaur criteria or a very similar score called fever pain. Generally, Centaur seems to outperform fever pain, so I would just use Centaur. And essentially, for cases that have a very low probability of being group A strep, so a score of 2 or less, then we can just treat symptoms. We don't have to be swabbing. We don't have to be prescribing antibiotics. For those patients in the middle, we should be swabbing them. And then for patients who have a high probability of JES, this guideline does recommend that it's reasonable to offer them an antibiotic prescription even before you've swabbed. So to summarize, here are our major take-home points for pharyngitis. I would say that in patients where we suspect group A strep pharyngitis, we should be getting a swab. It's defensible based on the NICE guideline to treat empirically in patients that have high Centaur scores. For now, we don't have evidence that we should be changing our practice. But again, the data we have to support this are limited and based on older variants of group A strep. And I also want to acknowledge something that Dr. Chowdhury said, which is that even though we don't have data to support it, it sort of makes sense that pharyngitis could lead to invasive group A strep. If a significant number of invasive group A strep cases are pneumonia, well, that GAS had to enter their respiratory tract from somewhere. And there just aren't any really easy answers here. So coming back to our case, despite having tonsillar swelling and exudate and lymphadenopathy, it's still very hard to distinguish group A strep pharyngitis from viral pharyngitis in this patient. He is afebrile, he has a cough, his McIsaac score would be 2. So you treat him with NSAIDs, a single dose of dexamethasone. You swab him because you were sort of moderately suspicious about group A strep, but you do not give him an antibiotic prescription at this point. And you discharge him with good follow-up instructions. Okay, so now you're in RAS, and your last patient of the day is a 20-year-old woman. And she comes in and identifies herself actually as being the niece of the patient that you took care of over in recess. She heard her aunt is sick, and she wants to make sure that she doesn't get flesh-eating disease. She had visited with her aunt for 2 hours yesterday. So we've learned when to suspect invasive group A strep infections. We know how to manage them. But what do we do about patients or healthcare workers who were in contact with confirmed invasive group A strep cases? So let's talk briefly about the rationale about why we would consider prophylaxis. There's evidence that the attack rate of invasive group A strep seems to be much higher in people exposed than in the general population. So estimates range from about 66 to as high as 294 cases per 100,000. And again, compare that to in the general population, the rates are only 4 per 100,000 at the time this data was collected. At the same time, though, these numbers are based on 2 very small studies. So that number of 294 comes from a study in Ontario that found that out of 1,360 exposed people, there were 4 cases. And so the risks are still low, but compared to the general population, they seem to be quite a bit higher. And these studies are still the studies that inform the FACT guideline and the CPS statement on chemoprophylaxis. I should also give the caveat that we actually have very little evidence on the efficacy of prophylaxis. There's a signal that prophylaxis seems to decrease the risk of infection, but the studies that we have are very small sample sizes and fairly weak methodology. So with that said, who should we be giving prophylaxis to? So the FACT guidelines, which have not been updated since 2006, suggest that only close contacts need prophylaxis. And in truth, not very much evidence on prophylaxis has come out since 2006. So who qualifies as a close contact? So a close contact is someone who is a household contact for 4 hours a day over a week, or for 20 hours in a week. People who are intimate contacts or who have been sharing beds, people who've had mucous membrane contact or needle sharing. And this has been the last 2 weeks. We do not need to be giving prophylaxis empirically for school classmates, work colleagues, or sports contacts. There are some special situations that bear mentioning. The first is childcare centers. So guidelines recommend that in a home daycare, if there's even one case, all staff and attendees should be getting prophylaxis. In institutional daycares, they say, let's wait until there's one more case. So if there's 2 cases, then we should be giving prophylaxis to everybody. And in long-term care, generally all residents and staff require screening with swabs, but we don't empirically treat people just because they are also in a long-term care home where there's been a case. So for occupation, a reminder that the transmission of group A strep is through large droplets. So there's a specific definition of occupational exposure, and it's someone in which secretions from the nose, mouth, wound, or skin infection of the infected case coming into contact with the mucous membranes or non-intact skin of a healthcare worker. And that's within 7 days before the onset of group A strep until 24 hours of effective antibiotic therapy. So just being in the same room as a patient without PPE does not count as exposure. If you have worn appropriate PPE, there is no exposure. Occupational health at TOH has a form that you fill out when if they've identified a possible invasive group A strep exposure, and you basically go through it. And if you have not, let's say if you were wearing PPE, you can stop there. You do not need any prophylaxis. If you weren't wearing PPE, but you don't think any fluid from the patient came in contact with you, then again, you can stop there. You shouldn't be getting prophylaxis. And when we do elect to give prophylaxis, this is the regimen. So first-line treatment is Keflex at a dose of 500 milligrams QID. This guideline says 250, but again, it's because of it's from 2006. But Dr. Yadav and Dr. Chowdhury both say that they wouldn't change anything. It's our usual dose of Keflex, 500 milligrams QID for a total of 10 days. And so this patient, she visited with her aunt yesterday for 2 hours. She's not a household contact, and she doesn't meet criteria for being a close contact. And so for these reasons, no antibiotics are indicated for her. I would reassure her, tell her to monitor for symptoms, and then discharge her home. Okay, so let's review our major take-homes from today. Invasive group A strep refers to group A strep cultured from a normally sterile site. These infections can be deadly as they may lead to toxic shock syndrome, but while they're on the rise, they still remain quite rare, particularly in comparison to the total number of cases of soft tissue infections we see in the emergency department. We reviewed that necrotizing fasciitis is a clinical diagnosis, and we should not be relying on imaging or lab tests to rule it out. We established that for now, management of pharyngitis should remain unchanged, with the caveat that the data we have informing that are not great. And finally, we discussed that only close contacts of invasive group A strep cases require chemoprophylaxis. I want to offer a sincere thank you to my supervisor, Dr. Yadav, and my other supervisor, Dr. Cortel LeBlanc. A big thank you to Dr. Chowdhury for his expert ID opinion, Dr. Hardy for his plastic surgery opinion, and then a huge thank you to my amazing study group. I'm happy to take any questions.